Good afternoon and welcome to the webinar entitled Back to the Future, Focused Ultrasound for Psychiatric Disorders. This high-intensity focused ultrasound has been evaluated as a clinical neuromodulation method for the past decade. Focused ultrasound has also been used in the treatment of essential tremor, Parkinson's disease, and chronic pain. Most recently, focused ultrasound has been studied in psychiatric disorders, especially obsessive-compulsive disorder and depression. Treatment-resistant psychiatric disorders have traditionally been treated by extensive brain ablation. The ability to ablate deep subcortical structures with a high spatial resolution through an intact skull makes focused ultrasound an exciting and interesting treatment tool in psychiatry. In this webinar, we will discuss neurosurgical treatment options for treatment-resistant psychiatric disorders. We will focus on the pathophysiology of these disorders, relevant brain circuits, and the rationale for introducing focused ultrasound for psychiatry. We will review the current experience with focused ultrasound for psychiatry and suggest applications such as focused ultrasound, neuronal excitation or suppression without damaging the brain tissue. I'd like to welcome Dr. Renana Eitan from Israel, who will be presenting this webinar. Dr. Eitan graduated the Hadassah Hebrew University Medical School in 2001. She's currently doing research at Brigham and Women's Hospital, Harvard Medical School. She is currently the founding director of research and neuropsychiatry unit at Jerusalem Mental Health Center, affiliated with Hebrew University. So welcome, Dr. Eitan.
Thank you, Susie, and thank you, the Focused Ultrasound Foundation, for organizing this important seminar. Thank you, Dr. Cassel and Dr. DeBlanc, for the opportunity to have this seminar with you today. So we'll discuss what is the future of focused ultrasound in psychiatry. I titled this seminar Back to the Future because you'll see that the focused ultrasound is the future, but we have to know what we have done before with psychiatric disorders, and we actually use the same old good things, but we can do it much better with the focused ultrasound. So mental disorders are actually very common and debilitating, and they are a major cause of disability and suffering for the patients. You can see that if we look at all the diseases that cause disability around the world, the mental and behavioral disorders are of the major part of this disability. You can see that from the age of 10 to 50 years of old, the mental and behavioral disorder are actually the major part of the disability. If you compare it, for example, to other diseases such as musculoskeletal disorders or diabetes or infectious diseases, you see that during the time that a person should learn and work, the mental disorder is the most disabled thing for these patients. If we look specifically what kind of mental disorders are most disabling, you can see that more than half of the cases are actually depression and anxiety. There are also patients with schizophrenia that have major disability. We also look at alcohol use disorders and drug use disorders as a major cause of disability in psychiatry. Unfortunately, up to 1/3 of psychiatric patients do not reach remission despite of optimal care, which is medication and psychotherapy, and they remain significantly disabled, and therefore they are classified as being treatment resistant. So there is an urgent need for new treatments option for psychiatric disorders. These new treatments has to be effective, of course, they have to be safe, and because we have a lot of patients, they have to be available for a large population. So in this webinar, we'll first discuss the principles of neuromodulation in psychiatry. We'll speak about targeting the brain with a focused ultrasound method. We'll see how neuromodulation methods can work for psychiatry, and we'll speak mainly about depression and obsessive compulsive disorder. And we'll speak a little bit about the role of focused ultrasound might have in psychiatry in general. So let's start with the principles of neuromodulation in psychiatry. So mental disorders are actually brain disorders. and stating that in 2019 seems obvious, but it wasn't always the same. And Tom Insel, the head of the NIMH, the former head of the NIMH, he stated in 2005 that we argue that psychiatry's impact on public health will require that mental disorders be understood and treated as brain disorders. So what does it mean that psychiatry is brain disorder? The mental disorders are actually disorders of brain circuits. If we take two diseases, for example, we take a neurological disease and a psychiatric disease. Let's speak about Parkinson's disease and obsessive compulsive disorder. So for both diseases, we can identify the clinical manifestation, okay? For Parkinson's disease, we can identify easily the posture of the patients, the tremor, the way they walk. It's very easy to diagnose clinically a Parkinsonian patient. For OCD, it's actually the same. It's very easy to look for the obsessions, the repeated thoughts, the compulsions of the patients. We know that there are specific types of OCDs, like dealing with patients that checks things, dealing with asymmetry, with cleaning. So we know the clinical manifestations of these brain disorders. We also can diagnose the patients by examining them, or by imaging, by histology, or by the genetic analysis. For example, for Parkinson's patients, we can have a DOPA test. We can look at the basal ganglia, or the specific area of the brain that accumulates dopamine. And we see that in healthy patients, we have these dopamine, and with Parkinsonian patients, we don't see that. For OCD, it's kind of the same. You see here a normal brain. This is an fMRI study, and you see an OCD patients, and there are differences in the activity of the frontal lobes of the brain. So what is the difference between Parkinson's and obsessive compulsive disorder? For most of the neurological disorders, we have a focal brain pathology. For example, for Parkinson's, we know that we don't have the typical substantia nigra. This is a specific nuclei in the brain. You can see that this is actually different from healthy people and Parkinsonian patients. For psychiatric disorders and for OCD, we don't have a focal brain pathology. So we say that the disorder is the disorder of brain circuits. So something about the network of the communication within the brain is causing the disease. What do we know about brain circuits in the brain if we talk about psychiatry? So we actually know a lot. During the recent years, we learned a lot from fMRI studies, from lesion studies, and we know that for specific behaviors and specific cognition, we can then identify specific networks. For example, for the positive effect, we know what are the main features or the main areas of the brain that are involved in the communication for producing the positive effect or for producing attention, for example. And we know that the areas that connect these brain areas are also very important for this network. So we know that if something goes wrong with this network, we get the psychiatric disease. So how can we change this network? If something is wrong with a specific disease, how can we change a brain network? So we have a few potential brain targets for neuromodulation that you try to modulate the brain. And this is one of them. This is an example of the limbic system. And you can see that the limbic system involves many areas of the brain, the frontal areas, which regulate the executive functions, the cingulate cortex, which communicates with other areas of the limbic system, the precuneus area, the amygdala, the insula. All these areas are connected to the big area, the limbic system, that controls the mood. So actually, if we want to change something, we can change the whole system of the limbic system. But it is, of course, a very wide target for neuromodulation. So we would like to look for more focal targets for neuromodulation. And one of these targets are actually the basal ganglia. The basal ganglia are these are nuclei deep inside the brain. And in the basal ganglia, widespread information from the cortex comes through the corticostriatal pathways and converge into a small nexus. After a very sophisticated processing that takes place inside the basal ganglia, the information returns to the cortex. So you can see that the projections of specific modalities of the brain, of the motor, of the cognitive, and the limbic information that goes through the basal ganglia actually allow the integration of the knowledge from the specific areas. And if we want to modulate, we can get into a very small area of the brain. These are the nuclei of the basal ganglia, and that's to make sure that we modulate the whole system, because this is actually the brain of the brain. But we have to make sure that we neuromodulate the right target, okay? If we want to target the limbic or cognitive network, we don't want to neuromodulate the motor symptom, because that will be side effect of our stimulation. So there are many suggested targets for neuromodulation in psychiatry, and you can see most of the areas that you're probably familiar with that are related to the limbic and the cognitive system, such as the orbitofrontal cortex, the dorsolateral prefrontal cortex, the anterior cingulate cortex, but we have to, or the striatum and the amygdala. So each one of them could be a potential target for neuromodulation, or the white matter that connects different areas could be a target for neuromodulation. So let's think, if we have a problem in my way, okay? You probably know, anyone knows this situation that you get stuck at the airport. Okay, so what can you do? If there is a problem like the Thomas Cook airport company, you have a problem with the company, or you can have a problem, for example, with the weather. So there are two things that you can do. You can change the airline company, okay? You can choose the same route, but just change the airline company. Or you can choose a different route for your trip. If you cannot go through a specific airport, you can use another airport or find another way. So this is actually what we do in the brain. If something is not working in our network, we can change the airline company, or we can modulate the brain circuit. We can use the same circuit, but try to modulate it. Or we can choose a different route. And in this example, we'll choose another brain circuit. If one brain circuit is not functioning, we can actually find another brain circuit. So this is actually the principles of neuromodulation in psychiatry. We have two major options. First, to modulate the brain circuit, and second, to choose another brain circuit. How can we do that? To modulate a pathological brain circuit, we can make an electrical modulation, we can use magnetic modulation, or we can use ultrasound modulation. If we choose another brain circuit, we have to ablate or to destroy the pathological brain circuit, and then the brain will find another way to process the information that we want, and it will pass the pathological network. So we can use a mechanical ablation, like thermal ablation or ultrasound ablation, or we can use a functional ablation, for example, electrical ablation, that we stimulate electronically the specific area of the brain, so it will not work. Of course, mechanical ablation is usually permanent. Okay, we just destroy this specific area of the brain or this pathological circuit. And usually functional ablation, it is reversible. We can stop the electrical ablation and restore the function as needed. So these are actually the principles of neuromodulation in psychiatry. Now we'll speak about targeting the brain with focused ultrasound. So let's So we now have a brain target for neuromodulation. But I told you that my favorite idea for neuromodulation are the deep structures of the brain. So how can I get into the deep structures of the brain? We have two main methods for targeting the deep structures of the brain. The first is a brain surgery. We call it a minimally invasive brain surgery, but this is invasive, of course. We make a small hole in the skull and we get into the specific area of the brain that we want to be at. This is a stereotactic frame. We can use it and find the exact place deep inside the brain that we want to target. The other method for targeting the deep structure of the brain is a non-invasive procedure. It's try to find a way without invading the skull to stimulate or to modulate or to ablate a specific area inside the brain. Okay, so now we are inside the brain, but how can we make sure that we're at the right location? So this is an example of a DBS procedure that I'll explain later what we are doing here, but you can see that there are adjacent targets and we want to target a specific place inside the brain. This is an electrode on the anterior limb of the internal capsule. This is a treatment, for example, for depression or for OCD. But how can we know that we are in the right target? Because we cannot see it, okay? We just have a small hole in the skull and we just put the electrode in. So how can we make sure that we put the electrode in the right place? Why is it important to know that we put the electrode in the right place? This is an example from a DBS study for OCD. You can see that even if you move a few millimeters before or after the target that we have, the procedure will not be as successful as if we target the right place. So this is very important for us to know that not only we choose the right target for stimulation, but also we can know that we located the procedure or the ablation or the stimulation in the right place. So we can do it first by imaging. Okay, we can take the anatomical structure of the brain. We use MRIs and we can look at the deep structure of the brain and find the right place for stimulation. We can also use functional imaging, which means that we can look at the fibers that goes from the specific area that we want to stimulate or ablate, see where they are connected to, what are their connections with other areas. This is an example from a study that compared different areas of stimulation for OCD. And you can see that even if you target specific areas within the same network for OCD, you can affect the same areas in the frontal lobe of the patient. So we can use functional imaging to make sure that we are at the right place. And we can also use electrophysiology. We can look at the electrical signal from the brain. We can use EEG, okay, electrodes from the outside, but we can also use electrophysiology from deep inside the brain. If we put an electrode inside the brain, we can also record the electrophysiological activity as we go down with our needle. And then we can make sure that we are actually at the right place. And if we are not at the right place, we can correct it a little bit. So we have three main methods to make sure that we're in the right place: by imaging, by functional imaging, and by electrophysiology. Of course, that if we're not getting into the brain, we cannot have the electrophysiology from the inside of the brain, but this method can be used in partly in the DBS procedures. So what is the focused ultrasound about? So as you probably know, the ultrasound the waves are similar to the acoustic wave that we hear. And there are many, many uses for ultrasound. This is the principle of an active sonar. We know that you can use the waves of the ultrasound for many utilities. But this is the focused ultrasound for the medical use, and we can actually use the focused ultrasound as a non-invasive treatment for neuromodulation. We have a few transmitters of ultrasound here, and they all focus the waves into a specific area of the brain. This is the area that we want to ablate or to stimulate, and thus we can get an effect on this specific target. So how can we know that we are in the right place? So most of the devices are guided by the neuroanatomy. So they are MR guided. We use high frequency focused ultrasound. So you can see that we get the patient into the MR device with the focused ultrasound. So we can know when we do the procedure that we are just at the right place according to the MR system. So this is how it looks like. The patient is in the MR. You can see that these are the area of the transducer, the ultrasound transducer. We have here a cooling device. This is the water, so the scalp will not get too hot. And then the ultrasound wave should penetrate the skull and get into the focal spot that we want to treat. So one of the major challenges in neuromodulation with focused ultrasound that wasn't there with other utilities of focused ultrasound with different areas of the body is actually the skull. The skull is a major barrier for the ultrasound wave, but they found a way to overcome this problem. So we actually measure the skull here, and we know how to make sure that the wave, the ultrasound wave that gets into the specific spot will be at the same timing or will be synchronized with other waves that come from other transducers. So we change the angle of each transducer, and we also change the timing of each transducer, so the net effect will be maximized. So this is the way, if you use a lot of transducers, and we know to synchronize all of them into a specific spot inside the brain, we can get an ablative effect in the specific spot that we're looking for. So how can we use focused ultrasound for brain disorders? First, we can make a thermal ablation. And that was done for essential tremor, and this is now FDA approved for essential tremor. This is under investigation for other diseases such as Parkinson's disease or neuropathic pain, epilepsy, and also OCD. We can use focused ultrasound for neuromodulation, okay, not to ablate the area, just to modulate the specific area. For example, we can do it with disorders of consciousness. We can also open the blood-brain barrier with a focused ultrasound and target drugs and deliver a drug at a specific place. And this has been done for brain tumors and for neurodegenerative disorders. And we can also use another technique of making air bubbles and using it to treat the patients. So this is just an example of how it looks like in real life. Okay, this is from a study of essential tremor patients, and they used to have thalamotomy. Thalamotomy, the thalamus is a big structure deep inside the brain, and we target a specific nuclei of the thalamus, the VIM. This procedure is known for many years to affect essential tremor patients, and these are the first cases that were done with a focused ultrasound. So you can see that before the surgery, we don't see anything. And here after the surgery, you can see the lesion. This is the focused ultrasound after 1 day, after 1 week. You can also see it here with different modalities of MR. So the lesion that can be produced by focused ultrasound is very effective for the treatment of essential tremor. Another example is the thalamic stimulation in disorders of consciousness. This is a different type of focused ultrasound device, but the idea is similar. These are low intensity focused ultrasound device, also guided by MR. And you can see that we can focus the area of the thalamus, and there are a few reports that it helped patients with after a severe brain injury. The focused ultrasound was also they used the focused ultrasound also to treat dementia, especially Alzheimer's dementia and Parkinson's disease dementia, targeting the hippocampus and the substantia nigra. It's a little bit difficult to prove that there is an improvement with dementia with these patients, but the preliminary results are very encouraging. So how can we use the focused ultrasound for psychiatry? We'll discuss mainly depression and OCD because these are the disorders that have most attention for the neuroablative procedures. So the ablative procedures for OCD and depression are not new, okay? For many years, the most severe patients with depression or with OCD had specific ablative procedures, such as the anterior capsulotomy. This is the anterior capsule and anterior capsulotomy, the anterior cingulotomy here, the subcaudate tractotomy, and a limbic leucotomy, which included these two procedures. And you can see if we look at the limbic system, these targets are major junctions within the limbic system. And for many years, it was known that these procedures are very effective. The problem was that these procedures had also a lot of side effects. These were open procedures. You have to get into a specific area. If you didn't target the right area and you accidentally ablate another area of the brain, there were a lot of side effects. So people tried to use these procedures only for the most severe patients. And not many patients actually got these treatments. If you look at the new technologies, for example, for OCD, so the same area of the capsulotomy or anterior capsulotomy that was used for many years for the most severe patients, this is a technology of thermocapsulotomy, open thermocapsulotomy, was also used for gamma knife capsulotomy, which is another way of doing an open capsulotomy, but also a target for new electrical stimulation of the brain for OCD, for deep brain stimulation. So if we look at this specific area, the anterior limb of the internal capsule, this is actually one of the most important pathways of mental processing. And it's not surprising that if we ablate or we stimulate this area, we get an improvement in OCD or depression symptoms. This is an example of the first patients that were treated with focused ultrasound for OCD. This is the same anterior capsulotomy as you've seen in the previous slide. And you can see the coronal sections of the MRI immediately after the procedure in 1 week. This is a bilateral capsulotomy for OCD, and it's actually as good as the old capsulotomy. The main difference is that this is a non-invasive procedure, okay? So with a focused ultrasound, we don't have to open the skull. We can just use the focused ultrasound to get it into the anterior capsule and to make the same ablation as we used to have with an open procedure. This is a very precise procedure and can get a very clinical, a good clinical result. So if we look at the data from anterior capsulotomy, this is the method for open capsulotomy, for gamma knife capsulotomy, and for focused ultrasound capsulotomy. This is the improvement of OCD patients. We measure that by the Y box. The Y box is actually a scale for the severity of OCD. The higher the Y box is, the more severe the patient's symptoms. So you can see that most of the patients are very severe. The Y box scale is from 0 to 40. So patients above 30 have a very severe OCD. And you see that if you look over time, this is an open capsulotomy. Within a year after capsulotomy, most of the patients got a major relief of their symptoms. And if they go from 35 to 20, we know that they are not as sick as they used to be. And now they can use psychotherapy to get relief of the symptoms of OCD. This is the same as we know that happens with the gamma knife capsulotomy. This is another method for open capsulotomy. You can see here the group that got the gamma knife capsulotomy and the sham control group. If we look at the focused ultrasound capsulotomy, the picture is the same. You can see that, again, we treat the most severe OCD patients, and within a year, most of them will get relief. The severity of the OCD will be much less than it used to be. So this is actually back to the future. The future is the focused ultrasound, but actually we do the same capsulotomy with the ultrasound as we did in the past. The main difference is that the focused ultrasound capsulotomy is not an open procedure. It's non-invasive. It's much safer, and it's much more precise than it used to be. So we are not surprised that this is as effective as the capsulotomy procedures, because we didn't change anything about the mechanism. We just made this procedure much more available and much more safe. This is a summary of the knowledge that we know about anterior capsulotomy for OCD. You can see that the number of the patients that were treated in different studies is not very big, and this is typical for these kind of procedures. You can see that the pre-operative Y-box, I mean, the severity of the OCD was very high. Patients with 34, 35, you see 32. Patients have very severe OCD and also very treatment resistant. And after the procedure, the Y-box has decreased dramatically. And if we look at the percentage of Y-box change, it's like 44%, here 36%. And these are the new focused ultrasound ablative therapy. You can see that there is a major change with the Y-box score, with about 60% of the patient that would be in a remission from their OCD. So we can see that the results from the focused ultrasound studies are similar to the results that we had at the past from the open capsulotomy procedures. What other options do we have for these patients? So another option is deep brain stimulation. This is another neuromodulation method. In this method, we put an electrode deep inside the brain at the specific area that we want to modulate, and it is connected to a pacemaker that is translated usually here. And you can see that actually this is the same place as the old capsulotomy. We put the electrode in the same place of the anterior limb of the internal capsule, and we do a high frequency stimulation. So we can say that this is a neuromodulation or electrical ablation, but in any case, this is actually the same anatomical area where we do the ablation. The deep brain stimulation is not an ablative procedure, and this is a reversible procedure, okay? And this is a major thing about the deep brain stimulation, that we have to remember that for deep brain stimulation, we have to open the skull, and we have this device which is quite expensive, and there might be some side effects related to the device itself. Other options for brain stimulation are actually non-invasive options. This is, for example, the transcranial magnetic stimulation. This is the BrainSuite device for deep transcranial magnetic stimulation, where we have actually a magnetic field that focuses into a deep area of the brain. It's actually not very precise to a specific area, but includes a larger area of stimulation. And we also have new modalities such as the transcranial direct current stimulation. And you can see here that these are like specific electrodes that we put outside of the brain. And when we stimulate them, we can stimulate specific area, especially at the cortex. but we know that this is a network. So if we modulate specific area of the network, we can actually influence other areas of the networks. So these are available treatments. But if we look at their efficacy, we can see that the non-invasive procedures are not as effective as the invasive procedure. If we look at deep brain stimulation, we have a few targets for deep brain stimulation, for depression and for OCD. These are the studies for OCD. You can see that the patients are very severe patients with a Y box of 33 or 34. And 50% will get into a remission. In different studies, it differs, but for the most severe patient, we can get a high percentage of remission. If we look specifically, we can see that there are many targets, potential targets for neuromodulation for OCD that were explored with deep brain stimulation. And we can say that most of these areas are effective for OCD, and of course, it's not surprising as we know that this is the same network. If we look at the clinical results of deep transcranial magnetic stimulation and TDTS, you can see first that the patients are not as severe, not have as severe disease as the invasive neuromodulation, so they are moderate OCD, not the most severe OCD. And the effect is not as high as the invasive procedures. The deep TMS procedure is about 30% of remission. And for the TDCS, many studies didn't find a high remission rate for those patients. So for the invasive procedure for DBS, we know that it works for OCD. I should say that the deep TMS is now, according to this study, it was approved by the FDA. So we can use it not for the most severe patients, but we can also use it for OCD. So what do we think is the role of focused ultrasound in psychiatry? So what do we know about the different procedure for neuromodulation and ablation that is available today for psychiatry? So if we look at the ablative procedure like capsulotomy, so we know that the thermal ablation and the gamma ablation, they are both very effective, and they were used for many years to treat those patients. The problem is that these procedures are very invasive, and they are not reversible. It means that you make the ablation, and if you made a mistake, you made a mistake. You can't fix it. The spatial resolution is good, and it's very focal. Another problem is that you cannot adjust the stimulation, or you cannot adjust the treatment. Okay, you do the treatment, and that's it. This is, the patient goes home, we did the ablation, and we cannot fix it or change it afterwards. The focused ultrasound, the new method for ablation, is also non-reversible, but it's also non-invasive. Okay, we don't have to open the skull to give the procedure. It has a very high spatial resolution. It's very focal, and it's probably very effective, but we need many more studies to prove that this is as effective as the procedure that we had. Of course, also with the focused ultrasound, this is a non-reversible procedure, so we cannot adapt the treatment according to the patient's state. What do we know about neuromodulation? So we spoke about the deep brain stimulation, which is very invasive. Okay, we're not only opening the skull, we put a device inside the brain, but this is reversible, okay, because we do not ablate the brain. So if we did something wrong, we can just turn off the device, and the brain stays intact. It has a very high spatial resolution, is very focal, and is also very effective and approved by the FDA. Another potential effect is the opportunity to adapt the stimulation according to the patient's state. So if I do the DBS procedure, the patients come to me every month or every 2 months. I check him, and according to his clinical state, I decide how to operate the DBS device. So I can adapt the stimulation each time for the patient. For the magnetic stimulation or transcranial direct stimulation, they are also non-invasive. They are reversible, of course, because this is not a permanent treatment, but the spatial resolution is not good. We don't know exactly where we stimulate, so this is non-focal. The deep TMS is actually FDA approved now, but it's not as effective as the old capsulotomy procedures or the DBS procedures were approved. We don't know if we can use adaptive stimulation. I think that in the future we will see protocols for adaptive stimulation for these procedures, but we don't have it now. So what would I want from a future focused ultrasound device? I would want a device or a method that will be non-invasive, like the focused ultrasound, and will be reversible. So I don't want an ablative procedure. I want a neuromodulation procedure with a focused ultrasound, that it would have the high spatial resolution that we had with the MR-guided focused ultrasound or the DBS. So I want it to be very focal, and of course it has to be very effective. Another advantage of the future focused ultrasound device, that it would be adaptive. So I can test the patient's state, or I can use neuroimaging devices and change the amount of the modulation that I will want for the specific patient for the specific treatment. So to sum up, what is the role of the focused ultrasound in psychiatry? Today, we can have focused ultrasound ablation as we have in OCD. So this is a one procedure. We don't need further intervention, and that could be an advantage in OCD patients. In OCD patients, part of the problem ultrasound. If you use a focused ultrasound, this is like a one procedure. We treat the patient, and we don't have any more questions about it. Focused ultrasound ablation can also be available for many psychiatric patients. As I told you before, we have a lot of patients that we have to take care of. Many of them have a very severe and treatment-resistant illness, and the DBS might not be the best procedure for so many patients. It's also worth mentioning that the focused ultrasound ablation is less expensive than other possible procedures. If we think about focused ultrasound neuromodulation, okay, so we can think about new focused ultrasound-based neuromodulation techniques. I think I need my slides. Okay, apologize for that. Some technical issues here. Okay, can we move forward? Okay, so for the focused ultrasound neuromodulation technique in the future, I would like to have maybe the focused ultrasound could be a subthreshold method for screening tool for potential target for stimulation. We have a lot of psychiatric diseases that we need to treat, such as depression, OCD, schizophrenia, anorexia, Tourette syndrome, or addiction. we don't know where is the best place for stimulation for these disorders. We tried a few targets with the DBS procedure where we go to specific areas, but we are not sure that these are the best targets for stimulation. DBS is an invasive procedure. I cannot put electrodes throughout the brain and find the right place. But with the focused ultrasound, if I can make a focused ultrasound modulation, not to ablate, of course, the whole brain, but if I can try and modulate specific areas, maybe I can find a better target for stimulation, for neurostimulation, for these psychiatric indications. Neuromodulation can also be directed by imaging, by resting, by functional imaging, by electrophysiology, not from the brain, but from outside the brain. And thus we'll be able to know what are the changes that occurs after the focused ultrasound neuromodulation, and then maybe we'll figure out what the best target for stimulation could be. We could also use the focused ultrasound for a targeted drug delivery for many psychiatric disorders such as anxiety, depression, and schizophrenia. Today we give medication and it affects the whole brain, different areas of the brain, but if we can choose a specific area for drug delivery, maybe we can make the medications much more effective for these psychiatric disorders. So this is it. This is my collaborators and student at the Harvard Medical School, the Brigham Hospital, and at the Hebrew University in Jerusalem. And I would be happy to answer some questions.
Dr. Eitan, thank you so much for sharing your expertise and your passion for treating patients with psychiatric disorders. Your description of the underlying etiology of brain circuitry in these psychiatric disorders was really interesting, and your overview of past and current procedures that are used to treat psychiatric disorders clearly describe the focused ultrasound potential to non-invasively accomplish similar outcomes to invasive procedures and surgeries. I'd like to ask you a few questions. I have a few questions already, but if any of you out there would like to ask her additional questions, please type these questions into the chat feature that's available on Zoom, or you can comment on the Facebook Live post. For now, Renana, I'd like to ask you a few questions that the audience has submitted. What percentage of diagnosed OCD patients are both severe and treatment resistant?
So thank you, Susie. We don't have an exact number of patients that are both severe and treatment resistant. Usually we would like to treat those patients that are both, of course, have a severe disease, and that we couldn't treat them with other options. We think that this would be between 20 and 30% of the patients that have OCD. This is the current knowledge, and the current knowledge is when we go to brain stimulation, we take only the most severe patients. But there are many patients that would actually prefer to have a neurostimulation and not to take medications. Many patients, we give them medication and they also need a psychotherapy, which is not always available, and not all the patients can go through a full psychotherapy treatment. So in the future, we would like to offer these kind of treatments to patients that are not only severe or treatment resistant, but patients that have a disorder that affects their life and needs treatment. Of course, we cannot treat patients with open procedures and ablative procedures if they have only mild disease. But if we'll be able to use the focused ultrasound as the neuromodulatory tool in the future, we could treat patients even more effectively with a focused ultrasound stimulation than a medication or psychotherapy. So for now, we are saving these treatments to the most severe and treatment-resistant patients. But we think that in the future, if we find the right target and the right method for neuromodulation, we will be able to treat a lot of patients around the world.
Right, that's interesting. And you talked a little bit about the complications of the invasive surgeries and the invasive procedures. Why would some patients who are not as severely affected not want to or choose not to take their medications? what are some of the side effects or poor side effects from the medications themselves that prohibit patients from wanting to be compliant with that medical treatment?
So there are two reasons, okay? We'll not get into the pharmacology lecture. This is another lecture. So there are, of course, side effects of the specific medications. For OCD, for example, people have to take a very high dose of SSRIs, which interfere with many aspects of their life. But I think that the major answer is that for the most severe and treatment-resistant patients, the medications don't work. And to take a pill every morning, or 3 pills every morning and 3 pills every night, and you still feel very bad, you still have a very severe psychiatric disorder, you don't want to take the drugs because they don't help you. So there are side effects, and the fact that the medications that we can give the patients are not very effective.
Okay. Here's another question. Which place along the circuit is the best target? And what is your belief in doing the ablation versus neuromodulation along the entire circuit, either involving one location, multiple locations? And can you elaborate a little bit on how to use focused ultrasound to find the proper place along the circuit?
So if you look at a specific circuit, we have specific nodes within the circuit that potentially could be a good target for neuromodulation. We actually don't know what would be the best area for stimulation, but it's not different from other neurological disorders such as Parkinson's disease. There are still arguments what is the best target for stimulation. So even like in Parkinson's, where we have a lot of experience in treating Parkinsonian patients, we're still not sure that we are targeting the best place. For depression and OCD, it's much more complicated. Because we don't have as many patients, of course, and experience, but there are lots of specific areas that we can target. The problem is that with the devices that we have today, like ablation and deep brain stimulation, we can choose one target, or if it didn't work, we can add another target, but we cannot test it for many targets along the brain circuits. So I think that the focused ultrasound in the future could not only find new targets for the population, but we can take a specific patient and look for the best target of stimulation for this specific patient, because we can try neuromodulation of specific nodes within this network, and then find the node that neuromodulation at this place will help the most for this patient. We can also use other tools of neuroimaging to look for the specific areas of this patient, to try to use functional fMRI studies before the procedure. But if we will have a good tool for neuromodulation, which is reversible, and we can just try different areas within the brain, that would be a major advantage, especially in psychiatric disorders. I hope that answers your question.
So can I clarify what you're saying is that you believe that this is really going towards personalized medicine, that we'll be able to take someone's individual case and do focused ultrasound anywhere from the cortex to the deeper structures along any of those limbic circuitry. So you're talking about personalized medicine for psychiatric disorders?
We are thinking about personalized medicine, so we can identify the specific network of a specific patient and try to modulate a specific area and try to fit the best treatment for that patient. We can also use this personalized paradigm to look for specific stimulation in multiple areas. Maybe one patient will need only one target for stimulation, or 2 or 3, or many targets for stimulation. So we'll be able to use focused ultrasound modulation for these patients. Another problem is in psychiatry is that the disease is not as defined as diseases that we see in neurology. Sometimes we don't know whether the patient has depression or OCD and depression. Some schizophrenic patients also have depressive symptoms. So if we can target, we can list actually all the symptoms of the patient and try not to go for a disease therapy, but symptom therapy. We'll be able to treat many more patients. For example, we'll have a specific network for psychosis, so we'll treat the psychosis. So if a schizophrenic patient would have psychosis, we'll target the psychosis network. But also if a depression patient will have some kind of psychotic symptom, we'll be able to help him with addressing the psychotic network. And that would be a major advantage in treating psychiatric patients.
All right, great. Let's see, some other questions are coming in. You talked about the small focal region of resolution with focused ultrasound as being 1 millimeter. Would you like to see a larger focal region for neuromodulation? Do you think that will be important?
I think that if we target the deep areas of the brain, which I think are most effective for treatment as we understand it now from our experience in deep brain stimulation, we would like to have a very small focal regions of stimulation. And if we need, we can add another areas for stimulation. But basically, we believe that if we go to the deep structures, as the subthalamic nucleus or the anterior limb of the internal capsule, the resolution that we need is about 1 millimeter to target the specific limbic and cognitive areas of the brain.
Okay. Do you have an anticipated date for FDA approval and availability to the general public?
So we know that getting the FDA approval is a very long process. We need to prove that this procedure is safe and effective in those patients. For the ablative procedures, we now have an FDA approval only for essential tremor, but there is an intensive work for getting the approvals also for Parkinson's disease, and we're trying to set up some big studies for OCD. So we hope that in the next few years we'll get the FDA approvals also for OCD ablative therapy.
Right, so currently the FDA has approved it for essential tremor and tremor-dominant Parkinson's disease. So yes, there's work in the near future to get this through FDA, and we have active steering committees and protocols that are eager to pass through the FDA to get them started. Another question just came on. Could a patient with severe treatment-resistant OCD who has failed other therapies be a candidate for focused ultrasound?
Okay, so we actually use these more advanced therapies for patients that failed treatments. Patient that actually failed deep TMS, 29 treatments for deep TMS is the regular treatment. So these patients can actually be candidates for more advanced treatments such as focused ultrasound ablation or for deep brain stimulation.
Great, great. Well, I'd like to thank everybody for joining us on this webinar. Again, Dr. Eitan, thank you for your expertise and your passion, and thank you for helping the field of focused ultrasound progress into this very interesting